Hey everyone, I'm Charlotte Marquis. I'm a board certified veterinary anesthesiologist, and today I'm going to be talking to you all about autotransfusion, and this is part 2 of 4. So this will be a practical demonstration and a little bit of how-tos about closed system autotransfusion. So in the first lecture, I talked about how closed system autotransfusion is we're taking blood from one place to another without really taking it outside of a set of tubings or really outside of the body cavity. So to elaborate a little bit more about what closed system is, so this is when we're just going to take it from one place to another and it's never going to be exposed to the air or the environment. So I guess a good follow-up question from that would be, how do I know if this is going to be right for my patient? So a good candidate for a closed system autotransfusion might be someone like an awake and emergency patient. So this is a patient that maybe has a traumatic or a cancerous hemothorax or hemoabdomen that you just do not think will make to surgery or will not survive to a certain point. So they need a transfusion now, and they need it the fastest way that we can provide that. So that's a great candidate. I also do this in pre-surgical patients. So if we have either a trauma patient or we have a cancer patient that is having surgery and has blood in either their chest or their abdomen, and I just do not think that they are stable enough to make it to surgery, I will usually do this because I can do it myself. I don't have to wait for someone else to start that for me. Furthermore, I also think that these patients should be small, or the anticipated volume of collection is usually less than 240, 250. Now I know that you can't measure it without looking at it and without getting it into syringes or a bucket, but if you have a patient that's less than 10 kilos or they have a very small amount of effusion when you scan it, this would be a fantastic candidate. The reason I say that is because otherwise it is going to be much, much faster to do open system autotransfusion because you can get the fluid out much faster. So in order to do this, you're going to need kind of a short shopping list, which I've set out here on the drape, and I will kind of hold up to the camera as we go. Me personally, I prefer some type of sterile table drape or a quarter drape. You want to make sure that all of your equipment you're doing this on, you're trying to maintain asepsis the best you possibly can. We know that infection is always going to be a risk from autotransfusion, so we try to minimize that the best we absolutely can. I like using sterile gloves. I know they're a little bit more expensive than regular gloves, but again, if you are taking a culture medium, so to speak, and putting it one place to another, I think that would probably be the best idea. Whatever helps you sleep at night. Ultrasound can be a really great way to help find pockets of fluid. I would recommend this. I think it's helpful. Large bore, long IV catheters. So we know that the larger the bore and the shorter the catheter, the better fluid flow. But I like the long catheters for autotransfusion because if you are putting it into the chest or the belly, what sometimes happens is that things like the omentum or the lungs like to butt up against the catheter. So if you have a longer catheter, I feel like that's a better way to just have more options to like wiggle the catheter around if the fluid stops flowing for whatever reason. Three-way stopcocks or male-male adapters, depending on how you're going to give this. This is going to allow you to take it from the body cavity into the IV catheter or into the fluid bag. IV extension sets and administration sets. So when you are doing closed system, it's going to go from the belly or the chest into the fluid collection bag. And a great way to do that is just popping a fluid extension set on the end of the three-way stopcock. Also, if you are delivering blood products, it still does not change if you are giving the patient's own blood back. So you still need to give some type of filter. The community is currently split about what types of filters we need to use on these. There are certainly concerns about gross material. There's also concerns about cancer cells. Right now, the only way to definitively get rid of cancer cells is using something called a leukocyte reduction filter or an external filtration system. Lots of people don't have access to that, and I would make the argument that if the patient is sick enough to need this, you do not have a choice, right? So this might be what you're working with. So you can use a blood filtration set, which is like a 200 micron filter, or you can use like the tiny square ones. This is usually around 18. Does it get rid of all the cancer cells and bacteria? We're not sure yet. ongoing area of research. So without further ado, I can demonstrate how I would do this. So for the purposes of demonstration, we have this table drape. You can also use a quarter drape. You can use like a little wheeling stand if it's just you like doing this by yourself. We're gonna pretend that this is the patient today. This blood is very deoxygenated, not looking so good. So this patient needs help. So we'll just have that there. Other things that I have, this is a 16 long catheter. So something large, something big is what you want. Fluid extension set, 3-way stopcock, filter, other filter, sterile gloves, Luer Lock 60. I think if you have a big patient or really just to save yourself time, just get the biggest one you can find. Collection bag. Now, this one happens to have anticoagulant in it. Again, the community is currently split about, do I use anticoagulant or not? The criticalist anesthesiologists and ER doctors cannot really decide what they do. Most people use anticoagulant, like 50-60% of them do. Here is my argument for using it. If you have a patient that had some type of trauma, or they have a cancerous mass that is bleeding, theoretically, if the blood is already somewhere, it's ongoing, like it's done with fibrinolysis. That's why it doesn't clot, right? However, if you do not know if there is active bleeding, and like, how do you know? Like, are you sure? You should probably put anticoagulant in there, because if you don't, and there is ongoing bleeding, there is a risk of clot formation. So I think it's about risk benefit. Have the conversation with your care team, have the conversation with the owner. But again, if the patient is this sick, you probably do not have a choice. So I personally do it. The word is still out. Okay, so how actually do I do all of these things? So for closed system, I'm gonna get my gloves on. And you can do this either in the awake or the anesthetized patient. You know, most of these patients are they're pretty crispy. They'll let you do it awake. Doesn't really matter. All right. So if I had an ultrasound probe, now would be a fantastic time for me to scan the patient's abdomen or chest and just find an appropriate fluid pocket. I personally think that when it comes to the abdomen, it usually tends to be very dependent, which makes sense. It also tends to be near the umbilicus. So if in doubt, go there. Large, long catheter, I'm gonna scan for my fluid pocket and I'm gonna find some place to put it, and I'm gonna get the catheter into some part of the animal. And at this point, blood would flash back into the catheter, and I would leave the catheter sheath inside of the patient. The next step would be to get some type of fluid set onto the source of blood. And now you need a way to start connecting this to a place you can aspirate it from. So I got an extension set into the blood source, and now I put it on a 3-way stopcock. The next thing that I need to do is get a syringe on there. I like the 60 because I don't like wasting time. And then what you can do is I'm gonna put this directly into an anticoagulant bag. So I'm just gonna get a fluid set on my anticoagulant bag and get it right on the 3-way stopcock. And then what you're gonna do is now you can aspirate blood into your 60 ml syringe. So you are taking it from the patient's body. Okay. Didn't have any red food dye, so this is what we're doing today. This is chlorhexidine solution. And then just like what you've learned with other aspiration sets, you flip the stopcock the other direction, and now you're gonna push it into the bag. So for those of you who have really strong eyes, you can start to see that this fluid is traveling from here to here and goes up here. So theoretically, I could do this all darn day. I typically go until either one, the patient is done getting prepped for surgery if I'm doing this on a pre-surg patient, or until they stop getting fluid. Just take what you can get. If the catheter gets clotted, you can wiggle it around a bit. You can always try another catheter, especially if you have a patient with hemoabdomen or hemothorax. Sometimes there's little fibrin clots in there. Sometimes the mesentery or the lungs might try to butt up against the catheter, and you can just go ahead and wiggle it a little bit, maybe scan with your ultrasound again, have another look. It is very important to keep in mind that if you are using anticoagulant, you need to make sure that you're counting your syringes. So this bag can accommodate about 250 mils of blood. So this is a 60 mil syringe. So I would be counting, or my assistant would be counting, how much did I put in the bag? So let's say I reached 250, or I got to a point where I didn't feel like I had any more fluid. I'm just gonna go ahead and disconnect my catheter from the patient's belly or chest. And then what I'm gonna do is, you have the option of either putting this filter This is always the fun part, so this part got stuck. But you have the option of putting the filter on the end of the delivery set, or you take your blood set and you get it in there. And now we have blood that was collected from one place that can go to another. Just takes a moment for us to get organized here. Here we go. Yeah, and now we have blood that's collected in a bag with anticoagulant that we can hang on the fluid pole and deliver to the patient.